Welcome to Raise the Line with Osmosis from Elsevier, seeking solutions with leading experts on how to increase healthcare capacity so people can get the care they need during the pandemic and beyond.
Hi, I'm Shiv Gaglani. Regular listeners to Raise the Line know that so-called rare diseases aren't really rare when you consider up to 30 million Americans are affected by them directly. That's nearly 10% of the U.S. population and makes it likely that there's probably someone you know who is impacted, or you know one of their colleagues, friends, or loved ones. That fact has hit home to those of us at Osmosis over the last few months as we've started planning a major focus on rare diseases for 2023, which we're calling the Year of the Zebra. Several teammates have come forward to share their rare disease stories, and we'll be sharing some of those with you on the podcast, starting with our Director of Nursing Education, Dr. Maria Pfrommer, and her husband, Jack, who are with us today. So thank you both for taking the time to join us.
Thanks for having us.
So, whenever we do these two-person interviews, I like to call on people specifically to answer different things. So I'm going to start with you, Maria, because obviously a lot of our team knows you really well. And a lot of our audience has benefited directly from the work that you lead for us in nursing education. So for those who haven't had the opportunity to hear you on the podcast yet, Maria, do you mind telling us a bit about your professional highlights and what drew you to the nursing profession?
Sure, Shiv. Thanks for having us on the podcast again. I really appreciate it. And the opportunity to kind of give our story. I think it's important, especially since, we're going through this currently with this rare disease diagnosis. Jack and I met back when I was going through working myself through nursing school as a single mom. I worked construction, and Jack and I were friends for a good 11 years. We finally hooked up, and this month will be 25 years, huh?
Yes, congrats.
So we were married for about 25 years. Eventually I did become a nurse, and after I got my first nursing degree, then I started getting into education and whatnot. So I've been in education and also a practicing family nurse practitioner for about 20 years now. I've been with Osmosis since April as the Director of Nursing Education, where I lead a very creative team of nurse educators, and we create Osmosis videos for undergraduate and graduate nursing. I also teach in nursing. I teach undergraduate and graduate.
Yeah, I know, it's amazing. And your team is wonderful, obviously, and just celebrated our milestone of over 600 nursing videos that were just released. So congrats to you all on that. More importantly, congrats to you two on celebrating 25 years together. So let's turn to you, Jack. Can you tell us a bit about some of your personal and career highlights?
I did construction work as something that my father did, and I did that when I got out of high school, and that's my highlight. I played music in bands, did all kind of crazy stuff back in my day. But
that's awesome.
I thought it was funny though, Shiv, with Jack. So he was in high school and he was in this special program. It was a pre-med program. Kids that had a very high interest in going to med school or nursing school, they had a special program for him. And he graduated high school, and that summer his dad said, "Come on, kid, you're coming with me. We don't have money for you to go to college."
You're a little sure. That was like late 70s. Like I graduated 80, and we had just been in a recession. So the country was, there wasn't money. There wasn't money there. So he said, you're going to work with me tomorrow. You're not going to the Jersey Shore for the summer with your friends.
Yeah.
So.
And then he saw me going through school and said, "Forget it. I'm not doing it."
Well, absolutely. Well, I mean, that's sometimes how things happen. Obviously, we're going through a recession right now, and people are obviously going through different decision making. Do I go back to school or not? And obviously, I have a news to share on that front. But Jack, so let's go back to you. I know, unfortunately, you've been dealing with this health issue since I think June. You were diagnosed with the rare disease or zebra retroperitoneal fibrosis, which I never heard about in med school, and I doubt many of our listeners have heard about it. So can you take us to the very beginning of your experiences and talk about some of the first symptoms you noticed?
I had been diagnosed with irritated, when I was 28, irritated bowel, which progressed into Crohn's disease. So I had been getting treated since I was 28 for that. And I had a doctor that was getting ready to retire, a gastroenterologist, and he said, "Let's get a CAT scan of your digestive tract. Make sure everything's on track before you go with somebody new." I had that done, and I was going to my family practitioner. I was having some sinus issues. We were treating it with short course of steroids. So it kept returning, and then I got some blood work done, and he said your creatinine rate is high, showing that you're having a kidney issue. And I had got the CAT scan the same time in the same time frame, and we forwarded it, and it showed I had a mass in my retroperitoneal area, a thin mass, but it was spanning across the pelvis. So when he looked at that, he concluded that my ureters were being displaced from that, and that's what you get with retroperitoneal fibrosis, and then it restricts your kidney function. So we went to the hospital. He suggested going and getting nephrostomy tubes put in, and when I was on immunosuppressors for the Crohn's, so oncology came in, and they wanted, we talked about biopsies and stuff because I was on immunosuppressors, and that leads you to be susceptible to lymphoma. So they did biopsies, didn't find anything conclusive. So our interventional radiologist said he thought it was this retroperitoneal fibrosis. So Maria went to the computer and did the research and said we looked for somebody who specialized in it. She found 3 people. We were able to get in at the Mayo Clinic in June, and they were the ones who did the final workup. But after a PET scan, they found that I had a small lymphoma in my back, and that came back as B-cell follicular lymphoma. So their conclusion was the lymphoma was causing the inflammation response in my retroperitoneal because they didn't find any B-cell involvement when they did biopsies down there. So that was about where we were at. And then between Mayo Clinic and our local hospital, they came up with a treatment plan, and we're in the middle of the treatment plan currently.
Yeah, I mean, definitely turn to Maria and talk more about the clinical workflow that you went through. But how are you doing now, Jack? Like, how are you actually feeling? And you're going through the treatment, and
I'm having mild side effects from the chemotherapy that they came up with. It's not like a very harsh chemotherapy. It's bendamustine, and it's not very harsh, but they're giving you after I get my treatment, it's a 2-day thing. They're giving me a bone marrow stimulator so that your counts don't drop you recover faster. I'm having more issues with the bone marrow stimulator that they're giving me than actually with the chemotherapy. Like, kind of, you have to lay low for about 4 or 5 days after you get it. So that's my issue. I feel as though I'm doing very good with what I got going on. I'm still staying active and doing stuff. So people I know from work that they're all retired and stuff, they're like, I can't believe you're still out doing stuff. Everybody else just packs the door and you see them 6-8 months later. I said, I don't feel like being that person. So
that's often the best approach, right? To stay positive and keep active as you are. And obviously you have great support in Maria, not only as your spouse for 25 years, but also your clinical background, Maria. So maybe you can give us your take as both the spouse wearing that hat, but also your nursing provider hat about how this has gone down.
Oh, goodness. Shiv, I have to tell you, I work with some of the brightest minds in medicine. It's Cooper University Hospital. They have MD Anderson, like an affiliation with MD Anderson. It's a trauma one center. They have a medical schools associated with it. And aside from COVID, this particular instance where Jack went in the hospital, I was really surprised when these greatest minds in medicine came up and said, we really don't know what this is, Maria. And then we think it is retroperitoneal fibrosis. And then I asked, well, how do we treat that? And a surgical oncologist with 30 years experience said, I don't know, I'm an oncologist. Look it up, Maria, and you're probably going to need to go to Penn or Mayo or something like that. So as I mentioned earlier, I teach in nursing. And so I am a full professor in a small school that is owned by Penn. So I thought, oh, I have plenty of connections. I should be able to get right into Penn, and was unable to do so. No one really knew what it was to begin with. And so in either case, I was able to get into Mayo Clinic. And as Jack said, then we went out there and we got the diagnosis. So it just was hard for me because they were so baffled, and I'm not used to that. I mean, these are physicians and team members that always have the answer and the clear path. And, so from that perspective, I think I was just a little unnerved. And then also too, I think with the retroperitoneal fibrosis and not really knowing what that is after 20 plus years experience practicing and looking it up, I have access to really strong databases that give me the evidence. I was able to come up with experts in that field, although rare. We knew we would have to travel if we couldn't get into Penn. And even the Penn, it was like people that were coming out of their residencies and fellowships. So anyway, so we were able to, thank God, get in to the Mayo in Rochester, Minnesota. So it's just, it was very, very different for us to go through that from all the perspective. And the thing is, I knew everybody. It was the hospital. He went to the hospital where I worked. So it was very much, we were all on first name basis, colleague, that kind of thing. So, they were pretty straightforward with us. They've been very collaborative. Mayo, when we went out to Mayo, the first rheumatologist, Dr. Michael Koster, his name is, he specializes in retroperitoneal fibrosis. He insisted that we get a PET scan. Insurance wasn't covering it. So he kept doing the appeals. And finally, he said to us, I'm going to keep fighting this, but there's a chance you might have to pay for it. What did they say that was? $8,000? $8,000 for this PET scan. We said, do it. We traveled all the way to Minnesota. We'll fight with the insurance later. So thank God he did do that, because then they found this follicular lymphoma. The term he used is paraneoplastic, meaning that lymphoma is causing the retroperitoneal fibrosis. Ordinarily, by itself, they wouldn't even treat the follicular lymphoma. They would watch and wait, and someone Jack's age, and they may PET scan them every 6 months until the cancer actually flares up. But the fact that it was causing this urinary obstruction, it was the opinion of Mayo Clinic and Dr. Koster that we then be treated from an oncologic approach. And then we'll see what sort of is uncovered with the retroperitoneal fibrosis. So that's sort of where we're at right now. He's treatment 3 out of 6. And at this point, the end of the month, right, you'll get a PET scan, and they're going to go from there. And the main thing that they're looking at is the urinary obstruction. And so far, he's been doing pretty good. He actually had one. So he went from getting nephrostomy tubes to urinary stents. And the last stent, so he gets those replaced every 3 months. And the last replacement, they were actually able to take out the right stent. So he only has 1 stent in now. So we're hopeful that with this chemo, so he's getting rituximab and bendamustine. That's the combination that he's getting. And then Neulasta. Neulasta is the one that's given him the hardest time. But anyway, it's like 3 days of treatment. And then basically they're hopeful that this may reduce the inflammation in that area, and then he'll be able to get the stent out, which is going to be directing the treatment plan. So Mayo will do all overreads of all of our testing and our blood work, our PET scans and whatnot. And MD Anderson and Cooper, they're all working together collaboratively. So we're doing a lot of telehealth with Mayo right now. We're not necessarily traveling out there. Sorry, I trailed off, but that's what's going on.
That's really helpful. Appreciate the detail. I know our audience will as well. So what, you've obviously connected with the leaders at Mayo in this particular condition, and have a really good clinical setup, it seems, between Cooper and Mayo. Can you talk to us a bit about maybe, connecting with other patients, or is there like a strong retroperitoneal fibrosis or lymphoma community that you've connected with?
Well, actually, he's pointing to me, but I only initiated it. He's actually on it all the time. So there's a couple social media groups, and we're pretty active on Facebook, just social media, just sharing pictures and whatnot. And there is a retroperitoneal, RPF for short, if you will, RPF group on Facebook that is actually run by a very knowledgeable fella that it was able to kind of give us more information. And then patients, from what we understand, some patients, it takes 3 and 4 years actually to get diagnosed. So Jack is on there all the time, and we're always kind of keeping up to date and communicating with other folks around the world, actually, that sometimes we have to use the translator, but that have RPF.
Yeah.
Did you find that helpful, hon?
Yes, they have to. People go on when they get their treatment plans, and they'll ask people, does anybody know, what are the side effects of this? I'm getting this treatment. Has anybody got it? What are the side effects? How long are you on it? A list of questions. And then other people in the group, if you go in there and you look, you can make a comment, tell them that, I'm getting the same treatment. I had this effect, this side effect. This didn't bother me. And, what your duration of treatment was, that type of thing. So.
That's awesome.
Surgical options. Yeah.
Yeah, finding those community support groups are important for anyone dealing with the healthcare system, but in particular, it seems for people with rarer conditions where it's, it's hard to connect. And I can't imagine how people used to do it before we had, technology and the ability to connect with people. Because I don't know, do you happen to know how common RPF is? I'll have to look into that, and clearly we want to make an osmosis video about it at some point.
No, I would need to look up the incidence, and it's kind of scattered, to be honest with you. I did kind of look into it, and it was like 1 in 100,000, but then it just depends on where you look for that information. In terms of like the actual clinical picture, that can vary as well. It's a term called idiopathic, whereas most cases of RPF are unknown for the causes. However, there is a strong correlation between autoimmune disorders, and Jack has Crohn's, and Crohn's is an autoimmune disorder. In fact, he had been treated with a medication that also put him at risk for this follicular lymphoma. It's called Remicade. So anyway, their thinking is that those two factors put him at the highest risk for this retroperitoneal fibrosis. There's, like I said, there's growing body of evidence, and the fact that it's a rare disorder is, kind of limiting the research, I think, because there's just not that many people. But IgG4, which are a series of autoimmune disorders, that is also something that they tested Jack for, and that was ruled out. So he's negative IgG4, non-IgG4 RPF.
Very interesting. Yeah, we're definitely going to be doing, as I mentioned, a video on this, and leaning on you, Maria, and Jack for your experience as we produce it. So, taking it back to everything you've learned in the past 6 months since the diagnosis and now the treatment plan you're on, this is a question for both of you, and you can take turns. What advice do you hope our audience, again, current and future healthcare professionals, have when dealing with a patient who was just diagnosed with a new condition or a rare condition like RPF? What do you wish they did differently or better, or maybe who treated you who you think everyone should be like?
What do you think, Jack? Do you want me to start, or do you want to answer from your perspective?
I would say, like with anything, if you have cancer or anything like that, like we're learning trial by error, but you definitely would need to get second, third opinions. But everybody we dealt with said too many opinions isn't. There's never too many opinions. So if you can get in to see somebody and get somebody else's take on it, that will help you make your decision-making process. You get as much input as you can before you commit to the treatment plan.
So I guess I'm seeing it from all angles, because obviously, Jack being my husband, but then also as a nurse practitioner, as an educator, there's so many different facets when this was going on. But one of the things that always comes to mind that we always hear, we teach it, when we precept or, listen to the patient. And in this case, I have to say now, not just because it was my colleagues, but he was my only patient at the time. I hadn't been seeing patients, right? So listen to the patient, because especially with rare diseases, they're the ones that are really looking into it. And if you're not familiar with it as a healthcare provider, it's very helpful to listen to the patient. They know sort of what is going on, because they're the ones that are going through it. And then of course, not all signs and symptoms are going to fall into that certain box where you're looking to check things off. Jack didn't present typically with this particular RPF. I mean, usually patients have abdominal pain, and there is it takes, again, years for it to be diagnosed. And this was not the case with him. So an example would be this IgG4, for example. As soon as they were barking up the RPF tree, I started to look it up, asked my colleague, could we do a IgG4 lab? And they were like, why IgG4? And I said, well, there's a connection between autoimmune and this IgG4, and they readily did it. And it's not just because I'm a nurse practitioner, but I also think that they were listening to their patient, that this is what we're reading, and they wanted to reassure us that they're doing everything that they can, in order to do the connection. So I think it's also it's a very comprehensive approach. Being a nurse practitioner, one of the things that nurses and nurse practitioners really are involved very much in is the transitional care piece. Here we're dealing with highly specialized physician-led care, where the physicians are making that the diagnosis and then the initial treatment plan. But the transition from there, you don't just, the trapdoor doesn't just fall out here. You need, okay, do you need help with learning your medications, where to go and whatnot? That was one. And then the telehealth piece, leveraging the technology. We were very fortunate. I work remotely. I was able to get some vacation time and fly out to Minnesota. We flew out of Philadelphia. But as it turns out, they could have also done a consult via telehealth, and insurance, of course, paid for that. So that's something I would say to patients, and I actually give advice to as well, is, if you can't get in physically to see them, see if you can get a telehealth appointment, which, worked out really well for us.
That's great. I mean, and certainly, when you have a 1 in 100,000 condition and just a couple centers of excellence like the Mayo Clinic for RPF, being able to get to the experts nowadays with telehealth is critical, and until you can kind of squeeze in for a slot. Still on you, Maria, wearing your Osmosis hat, developing this education for millions of current and future healthcare professionals, has this influenced kind of what you think we should be doing at Osmosis or Elsevier in terms of covering these conditions, or, teaching our students to listen to the patient, as you mentioned? What are some takeaways that you think how this will influence your work even at Osmosis?
I have a script in my head. So we create videos, and we start out by writing a script, right? And one of the things that comes to mind from a nursing standpoint, we have a nursing product and then an advanced practice and nurse practitioner product. And so at the different levels of undergraduate and graduate, I could see having actually 2 different educational modules, and maybe even a certification at some point. I think you mentioned this before, that if we combine all the rare disorders, really the majority of diseases would actually, if we can combine them all together. But I think mainly, like from a nursing standpoint, with the bedside piece, if you're in the hospital, looking at the social determinants of health and the educational level of the patient, the understanding, sort of from a health literacy standpoint, what family members are involved, it's, for the support, and then also assessing the social determinants of health to make sure that they will be able to transition well from the hospital to the home. And then if not, creating those referrals. So for example, in the hospital, of course, we do physical therapy, occupational therapy, but maybe we need to mobilize a social worker. This is a patient that may not be able to get to and from appointments or may not be familiar with technologies to be able to take advantage of telehealth. All these assessments can be happening while the patient is inpatient. And then also ordering like a home care consult for a nurse to come out to the home, make sure that that transition is happening from the RN level, and then the nurse practitioner level, I could see that being more of a primary care. Well, I guess it depends on the specialty, but at that particular level, when the physician teams have made the diagnosis, following up with that patient from a disease management standpoint, making sure that all the preventative health is still going on. So, for example, Jack recently got his flu shot, pneumonia vaccination, and was boosted again for COVID. These are things a lot of patients of mine, especially when they're going through these specialty visits. I see a cardiologist, I see an oncologist. You need to see your primary care provider. And, need to see a physician at this point because it's such a high level type of disorder that he's going through, but then also too in between, having someone that can help you through those transitions. There's just so much to it. I mean, so much that we could probably fill up another podcast that I can absolutely see needing several videos just based on certainly retroperitoneal fibrosis, but just the whole. What do you tell patients that have a rare disorder? It's pretty scary when these great minds are telling you, we don't know. Some of the brightest minds in the world are telling you, we don't know. That's pretty scary from where I sit, from where Jack sits. So I think it's up to us. Honestly, we're obligated as, professionals to kind of let's address this and let's get it out in the open so that we do know that, oh, yes, you do have a rare disorder, but here's where you can go for that. These are the resources that are available to you. This is how you help transition this patient. This is what this patient's going to need. They're going to need to see this specialist every 6 months. In our case, they didn't even know which specialist handled it. We found that out on our own, that it's rheumatology, by the way. Initial diagnosis is rheumatology, right? You would think oncology, but it's rheumatology in his case. So anyway, those are some of like I said, it could be a completely new podcast just on nursing, nurse practitioner, and then of course, when the nurse practitioner should be referring over to the specialist and this whole physician level of care. The nurse practitioner needs to know what they don't know and also what they need to elevate to the next level. And there's a lot to that, you have to really be self-aware of what you can and can't handle at the level that we're at.
We found when we went to the Mayo Clinic, our rheumatologist said, well, you have something that's rare, and when nobody knows what it is or what to do with it, they kick it to rheumatology. So he said, that's why you're suing me. So he said, that's what we do here.
Amazing experience. 80 minutes, Shiv. They spent 80 minutes. Dr. Coster, our first appointment was 80 minutes with him. Wow. It was just the most amazing healthcare experience, Mayo Clinic,
That's incredible, yeah. Well, again, the nuance here, I think this is, again, one reason we're so focused on rare diseases, because one, it's very scary for the patients and the clinicians, like you, Maria, you're a clinician and a family member, to get a diagnosis that nobody knows much about or very few people know much about. So that's a whole course, and how do you, that we could develop together potentially. And we're talking about that in addition to the specific conditions. But then a lot of the major themes we try to get across at Osmosis, like listening to your patient, being, social determinants of health, care centricity, or care coordination with multiple different stakeholders, are things that, apply to diabetes just as they much apply to retroperitoneal fibrosis. But in the second case, they're a lot more stark because it comes out in a much bigger way. Patient literacy clearly is a big one. I know I've taken you guys 5 minutes over what we had allotted, but I did want to end with one question, which was, what else would you like our learners to know right now about anything, about you, about RPF, about your health journey, or just about being good clinicians and providers?
Well, from my perspective, as I already, went through, but I really think that we need to learn more about the rare disorders from every level of care. Also, what we all do as far as referrals go. We're also involved in continuing education here and what referrals you make. So, for example, someone would need probably physical therapy, occupational therapy if they've been in the hospital for a while, a social worker if any of the assessments that you make. So just when to elevate to a different level of care or when to refer to nutrition or any of the other disciplines. So the interprofessional approach, I think, is one of the things that and leveraging the technology, that is the biggest thing, that I'm very familiar with technology and do telehealth visits, but in this case, it was so helpful to have they have our backs, so it's really nice that Mayo is in there, overreading things, to get that second opinion. What about you, Jack?
As far as the rare diseases type thing, I guess when you get, I never heard of Crohn's disease before I was diagnosed with that. I never heard of retroperitoneal fibrosis until somebody has it, or you get something and they refer to that. Then all of a sudden it seems like there's all these people that, oh yeah, I had that too, but you don't hear about it because, some people don't broadcast. A lot of people don't broadcast their everyday, on a daily basis. Like I would say, like on social media, oh, I'm feeling really bad today. Like when I was getting treatment on Maria's, like, are you going to let people know? And I'm like, well, I don't want to be the Debbie Downer that brings the world down. I just, maybe we'll get treated, it'll go away, and that'll be it. I don't want to drag everybody else down with it. So, but I could see people feeling helpless if they can't get the resources they need. I think that getting the resources and having somebody pointing you in the right direction. I had Maria to advocate for me, but if I didn't have her and I was in the hospital, I mean, I could have been taken down the rabbit hole, and I'd be like people on the retroperitoneal site. They're like, I took them 3 years to get my diagnosis because nobody pointed them in the direction that they needed to go. And look, I was told, you didn't have any symptoms. And I said, no, I had no symptoms. I'm out golfing 4 days a week. I go to the gym. I would say I'm active for 60 years old, but I also told the doctor, I said I turned 60 and the wheels fell off. So, but I think people need to get that directional piece. If you don't have somebody to advocate for them, like the educational end would be having somebody, the nurses or whoever's doing the videos to take care of the patient by directing them in the right direction to what they, even if you're not, that's not your specialty, but you can give them resources and say, go A, B, C. If that's a dead end, you go to this is the route you need to take.
I feel like people need help. And the fact that I was able to be there and persist with, okay, yeah, we'll do the PET scan, even though the insurance isn't going to cover it. Most people don't realize, that you can appeal a decision an insurance company makes. So this persistence piece, I think, is key. And then also I noticed too that, a lot of people didn't know what was going on. They never heard of healthcare professionals. And I would encourage them to read the notes from the specialist who is diagnosing. It shows you the full workup. It shows you what that professional is thinking, and it will help expand your knowledge base as well. And then as a family nurse practitioner, I'm very adept at reading all different specialist notes and then putting everything on the same page for that patient. And I think that's why it's so important that the family provider and the family physicians are involved in a patient's care. They tend to get very busy with the specialist appointments, and they need to kind of come to home base and see their PCPs as well. So those are some of the things that I think we learned together that, yeah, you need help. Like, even if it's just a family member or recording the sessions that you have. With COVID, it's been really challenging. Visitors can't come in. So when sometimes I ran home to get a shower or whatever, I'd say, Jack, record the meeting with the doctor. If the doctor comes in, ask him if it's okay to record, or ask him if it's okay to FaceTime with me. Because even though two of us were in the room, sometimes we heard two different things. You know? So sometimes when we did the Mayo Clinic consult, we were like, are you okay? Hematology, I'm sorry. We also had a hematology consult, and they started the plan of care for Jack with the follicular lymphoma. I said, are you okay if we record this? You know, because there's just so much information coming at you, and it takes a while to digest it. And sometimes we went back to that recording and said, oh, that's what they said. That's why they're doing this, or that's why the staging is this and whatnot. So anyway.
Those are some really great insights, and we're definitely going to capture them. And obviously, Maria, excited to work with you and your team, both in the nursing side, but also the medical side, to create this content that hopefully trains not just the students and healthcare professionals, but also patients. I mean, and patient navigators and case managers, who are the ones who are actively in the room and trying to help that patient and their family, connect those dots, as Jack was saying, A, B, C, D. This is the path you go. So I really appreciate you both sharing your story. And as you know, Maria, like our mission at Osmosis, everyone who cares for someone will learn about osmosis. And we did that because, we realized that ultimately we are the patients. Everyone who has a body here is going to be a patient themselves or has a loved one with a patient. And unfortunately, I know, Jack, nobody wants you to have gone through this, though obviously you going through this has informed Maria, which will inform Osmosis to provide the best education to produce the most empathetic and caring clinicians we can. So really appreciate you both coming on and sharing the story. And obviously, Jack, let us know if there's anything we can be doing to be more helpful to you and your family as you go through this.
Sounds great.
Thank you for your support, too. Our teams have been fabulous with supporting us through this.
Absolutely. Well, thank you to our audience for checking out today's show. Remember to do your part to raise line and strengthen the healthcare system. We're all in this together. Take care.
If you like this podcast, please share it on your social channels. You can also subscribe to the series and check out all of our episodes at osmosis.org/raisethelinepodcast.